respected faculties and delegates, I am Dr. Sarvesh Goyal. I will be presenting on non-contiguous dual level spinal injuries. So non-contiguous dual spine injury refers to the presence of two or more distinct or separate spinal fractures that occur simultaneously but are separated by at least a single normal vertebra. These injuries can occur at different levels of the spine, such as the cervical and thoracolumbar region, and they are often overlooked during initial trauma assessments. These injuries are relatively rare. They account for a small percentage of spinal injuries, but it carries a significant risk of neurological damage and disability if not promptly diagnosed and treated. So, we retrospectively reviewed our database to analyze patients of non-contiguous dual-level spine injury who arrived at our tertiary care trauma center from Jan 2015 to June 2024. Following parameters were studied for the patients like demographics, clinical characteristic, mechanism, levels of injury, comorbid illness, coexisting injuries, how the management was done, the type of operative intervention, the ASIA gradings, and the outcomes, and any complication. So the results were, we included total number of 38 patients. These 38 patients were 3% of the total 1260 patients that were admitted of spine injury during this period. Most of the patients were male, that is 73.7%, and the mean age of the patient was 37.86 years. Most common mechanism of injury was fall from height, that comprised of about 57.9% injuries, and followed by high velocity road traffic accident, that was 42.1%. So out of 38 patients, the 30 patients, that is 79% patient has two non-contiguous segments, whereas 8 patients had more than 2 segments, that is 6 patients had 3 non-contiguous segments, and 2 patients had even 4 non-contiguous segments. The most common type of injury pattern was that cervical plus thoracic pattern, where one vertebra was in cervical and the second one was thoracic, and it was seen in about 40% of the patient. It was followed by thoracic plus lumbar pattern, which was seen in 13 patients, and the least common pattern that we saw was thoracic plus thoracic pattern, that was seen in a single patient. And one patient even had involvement of all the 3 segments, that is cervical, thoracic, and lumbar. So most common segment that was involved was thoracic, that was seen in 30 patients, that is 79% patients had involvement of thoracic segment, followed by cervical and lumbar. So the type of injuries encompasses the all the ranges. Like in cervical, at various levels we had odontoid fractures, hangman fractures, burst fractures, fracture dislocation, traumatic PIVDs, and we also had minor injuries like chip fractures, spinous and lamina fractures, or minor body fractures. And in the thoracic also we had major injuries like burst, fracture dislocation, major compression fractures, chance fractures at various dorsal levels, along with minor injuries like spinous process and lamina. Also at lumbar we had all different kind of fractures at various different kind of levels. The preoperative ASIA grading of these patients, we took the worst ASIA grading in this of both the segments, and the 13 patient had ASIA grading, that is 34.2%, followed by 10 patients were even presented with ASIA E grading, that is 26.3%. We also analyzed the associated injuries in these patients, like for in NCCT had 13.2%, that is 5 patients had abnormal NCCT had findings, which included either they had frontoparietal contusions, hemorrhagic contusions, and they had fractures of the occipital bone and cisternal bleeds, Felsine EDH, and one patient had right parietal depressed fractures along with EDH, which even required craniotomy and evacuation of EDH and elevation of the depressed fracture. And when we look at the other organ system, these patients can have very high incidence of associated findings, that is 55.26% patient had associated injuries. 40% patient had associated chest injuries, which include rib fractures, pneumothorax or hemothorax requiring ICD insertion. 18% patient had extremity injuries like long bone fractures, hand injuries, clavicle injuries, whereas even 2 patients had severe abdominal injuries including liver or spleen laceration, renal laceration, or retroperitoneal hematomas. So the management is based on standard protocols for each fractures. For example, for hangmans, we have the Levins and Edward classification, where we will like to treat type 2A, 3, and type 2. And in Anderson and DeLonzo classification of odontoid fracture, we will treat type 2, and whereas type 1 and type 3 can be mostly managed conservatively. And then for subaxial spine and thoracolumbar spine, we have the standard classification like SLICS, which includes the injury morphology, DLC, and the neurological status. And we had TLICS classification, which also include the morphology, the integrity of the posterior ligamentous complex, and neurological status. For both the SLICS and TLICS, if the score is less than 4, it's non-surgical management, and if the score is 4, it's the surgeon's choice, and if it's more than 4, then it's a surgical intervention. So according to these standard protocols, various kind of fractures were managed differently. Like odontoid fracture, we had anterior odontoid screw placement or posterior C1, C2 fixation. For cervical bus fractures, fracture dislocation, we had a variety of approaches like ACDF, antecervical corpectomy and fixation, posterior lateral mass screw rod fixation, and wherever deemed necessary, 360-degree fixation was also done, whereas minor injuries were managed conservatively. Similarly, for thoracic and lumbar spine, for major injuries like burst fracture, fracture dislocation, unstable compression, posterior pedicle rod and screw fixation, either open or MIS, or whenever deemed necessary, corpectomy and cage fusion was also done. So out of 38 patients, 19 patients, that is 50% patient, required fixation of both the segments, both the unstable segments, whereas 16 patients could be managed with the fixation of only one segment, and the other segment was stable in these 16 patients, whereas 2 patients required fixation of all the 3 segments. And in maximum patients who require fixation of only one segment, they can be operated in a single sitting, whereas one patient required 2 sitting to be operated. Whereas in 19 patients who required fixation of both the segment, in these 15 patients, we could operate both the segment in a single setting, whereas 4 patients required 2 operative intervention for fixing 2 segments. And the post-op ASIA grading improved in 4 out of 38 patients. So these are the illustrative cases. Like this is a 37-year-old female, fall from height, diagnosis D8 and L1 burst fracture, ASIA A grading for the D8 level. It was managed by pedicle rod and screw rod fixation of both the segments, as can be seen in the CT video. Another patient, 47-year-old male, fall from height, diagnosis odontoid fracture with C7 D1 antrolisthesis, ASIA A4 C7, managed with C1 C2 transarticular screw and C7 D1 360-degree fixation. Another case, 37-year-old male, RTA C7 D1 antrolisthesis with D10 chance fracture, ASIA E, managed with C3 to C5 lateral mass screw rod fixation along with D1 to D2 pedicle rod, and D8 to L1 pedicle rod and screw fixation along with C6 C7 laminectomy. So outcome, 36 patients who were discharged in stable patient, 12 patients who had cervical spine injury required tracheostomy. There were 2 deaths because of ventilator-associated pneumonia and multi-organ dysfunction syndrome. The literature on dual spine injury is very scarce. There are only 6 studies which discuss about these dual level non-contiguous spine injuries. The earliest study was done by Kalinov in 1977, and the latest that is available is by Wittenberg and Einstein in 2002. The prevalence in the study is also range from 3.2 to 10%. So the conclusion is non-dual spine injuries are very rare. 3%, they are seen in 3% of spinal injuries. They are mostly seen in fall from height cases followed by high velocity RTA. There are high association of chest injuries, abdominal injuries, and extremity injuries. So there is requirement of trauma surgeon and orthopedician also for the management of these cases. Most common pattern is cervicothoracic, followed by most common segment is thoracic. Whole spine MRI and CT scan is must to identify the cases. Patient can be between extremes of ASIA A or ASIA E. Surgical decision based on SLICS, TLICS, and standard protocols as per segment. Thank you.
Thank you, Dr. Sarvesh. Very nicely presented. My only comment says that you should focus on one take-home message, because there's so much happening in this paper or your study. For example, you showed us a case in which there was spondylolisthesis C7 over D1 almost.
Yes, sir.
With another associated injury.
Yes, sir.
And this patient is amazingly ASIA E,
yes,
no
sir.
deficits.
Yes, sir.
So maybe if you could focus on these kind of patients who are Asia, despite severe injury being ACIE, and then focus on the reasons why. Maybe metabolic, maybe he's ankylosing spondylitis.
Yes, sir.
So the second point I want to bring across is you should also focus if these patients are having multiple injuries, the reason.
Yes, sir.
The reason why they are having multiple injury. Is it 3-level, 4-level injury? Is it metabolic also association,
Yes, sir.
or is there something else? So then you have a award paper, you know, on this. Focus on one thing, irrespective of so much going on.
Yes, sir.
Thank you.
Yeah, good paper, Sarvesh. And to carry on with the same comment as Dr. Deepak has told, regarding those patients where you had multi-level injuries, was any DEXA, I mean, I know it's an emergency situation, but still later on, did you perform like whether they were old age patients with osteoporosis?
So the mean
Based on
age
the
was
imaging or-
37 years, sir, for the patient.
Okay, so that needs to be evaluated because sometimes you have this. And yeah, well presented. Maybe the take-home message should have been at least, how many of them improved? Was there any patient who presented with multi-level fracture and then they had some improved neurologically in the post-op?
Sir, 4
follow-up?
patients improved, 2 from Asia B to Asia, Asia A to Asia B, and 2 from Asia D to Asia E, sir. 4 patients improved.
So the consideration of the time of surgery also
Yes.
matters in these patients. Well done.
Thank you.